Hi, good evening, guys. So we were talking about EGD last Friday, right? So you guys, um, I think like let's see, pre 43250, you lost me, right? So we'll see that from the CPT 43250. So I hope you remember what are all classes, what are all things which I taught you on Friday. So coming to the CPT 43250, this is for removal of the tumor and polyps when a patient comes in for a guys, am I visible? Am I audible? And if is my screen visible, please confirm.
Yes, Soumya.
Yeah. So yeah. So here the patient comes in for the removal of any tumors or polyps by hot forceps biopsy. So I told you what is hot forceps biopsy and what is snare technique. So if the patient comes in, if he has any lesions or polyps, okay, and if he is removing his polyps through hot biopsy forceps, okay, using EGD, transoral EGD, then your CPT is 43250. Okay, now if the patient comes in to remove lesions or tissue or polyps, okay, through snare technique. Then your CPT is 43251. Okay, so whenever you're coding for removal of this lesions or tumors or polyps, please check whether it is through hot forceps biopsy or snare polypectomy. Sometimes they use it as snare polypectomy. So so that is one thing, and also make sure that these CPTs includes multiple removal of the lesions. Okay, so that is one thing. And then if a patient comes in for doing EMR, okay, right? I explained on Friday what is EMR, endoscopic mucosal resection. What are the criteria needed for EMR? So first thing, anyone can you tell me what are the criteria? Can anyone just unmute yourself and say what and all I taught on Friday, like regarding EMR? Yes, please tell me, guys. Nikhil, Bhuneshwari, who is this? Badusha, Kiran. What happened? Yes, Nikhil, tell me. What are the three criteria in order to code for EMR? I hope I'm audible. Yeah, so tell me. On Friday I taught you, right? Okay. What others? Bhuneshwari, Badusha, Kiran, and Swapna, Swati, Teju. Why you guys are not opening your mouth? Teju, tell me, Teju. What are the three criteria, Teju? The code for endoscopic mucosal resection. Now no one will open mouth, right? Nikhil, you can mute. Please mute yourself. I can't able to hear you. I know I'm very well audible to everyone over here. I'm not sure why you guys are not telling me the answer, or if you guys haven't noted down. I don't know. But anyways, I want to move on with the class because I can't just waste my time too. Fine. So EMR is nothing but if the three criteria which I told you on Friday is that if a lesion is identified, that is one thing. If a lesion is identified, then the second thing is that they will be doing in submucosal injection so that the lesion is elevated. Okay, and also it will make easy for the surgeon to excise that lesion. So that is the third criteria. So if these three criteria are there, then you can code for EMR. Okay. So then if they are, doing any method to control bleeding from the tumors or lesion, then you can be coding 43255. They are placing any endoscopic stent. Okay. Then your CPT is 43266. They're doing any ablation, like means, destruction of the tumors and polyps. In that case, we'll be coding 43270. So these are the CPTs for EGD, guys. If you're coding for EGD transoral, then these are your CPTs. Okay. Now coming to ERCP. So ERCP is nothing but endoscopic retrograde cholangiopancreatography. Okay, so these procedures are usually done to diagnose problems which are in the bile and pancreatic ducts. Okay, so they will insert endoscope through the mouth. Okay, to which goes down to the esophagus, stomach, and the small intestine to visualize these ducts. Okay, so they might also inject a contrast dye so that if there is any stricture, stones, or any tumors, it will be visible in the X-ray. Okay. Um, so that is one thing. And you can see here, so pancreas major and minor ducts, they will visualize in biliary tree, they will visualize the common bile duct, the hepatic, right and left hepatic, and the cystic or gallbladder. So all these, uh, you know, uh, areas, all these organs and all these ducts will be visualized through ERCP. Okay. So these are your coded for ERCP. So you have 4326 here. This for diagnostic purpose. Okay. If they are doing an ERCP only for visualizing, or if they are collecting any specimens by washing or brushing, then you will be coding under 43260 for diagnostic ERCP. If they are taking any biopsy, whether it is multiple or single biopsy, you will be coding 43267. If they are performing sphincterotomy, okay, if they are like performing sphincterotomy or papillotomy, it is nothing but they will just cut open the sphincter. Okay, so in that case, we'll be coding 43262. If they are measuring any pressure of the sphincter of OD, so it's a structure found in the pancreatic ducts. If they are measuring any pressures, then you'll be coding 43263. Okay. If they're removing any foreign bodies, whether it is stones or any debris, okay, from the ducts, whether it is pancreatic duct or biliary duct, whatever the duct is, and if they are you removing the stones, you'll be coding 43264. If they are destroying the stones, for example, through lithotripsy or cryotherapy or electrohydraulic methods, using all these methods, if they are destroying the stones which is found in the pancreatic or biliary duct, then your CPT is 43265. So all these are very straightforward code, guys. Okay, so you can see over here. You can see the left hepatic duct over here, the right hepatic duct. Okay, then you have the a hepatic duct over here, your the cystic duct, this is your gallbladder, okay, and this is your pancreas. Okay, so here you have the pancreatic duct, okay, so they will insert the catheter, they will insert the dye injection over here, okay. They are placing any stent. If they are placing any stent into the biliary or into the pancreatic duct, okay, you'll be coding 43274. Okay, and if they are placing one stent. So this CPT is for each stent. Okay, 43267 for each stent. If, for example, if they are placing one stent in biliary duct, okay, one part of the biliary duct, and if they are placing another stent in the opposite duct, Okay, in that case, we'll be coding 43274 and 43274 again for the another stent, another duct with 59 modifier. Okay, so this is how you have to code. You can see it here. So, for stent placement in both pancreatic duct and the common bile duct during the same operative session, placement of separate stent in both right and left ducts, or placement of two side by side stent in same duct, you have to code it with additional stent place. Okay, you have to code 43274 along with again for subsequent you'll be coding 43274 with 59 modifier. So that is what they are trying to tell you. Even if a stent is placed in a pancreatic duct and also another stent is placed in the common bile duct, you have to code both. Okay, you have to code 43274, comma 43274 with 15 modifier. Modifier is nothing but to show that there are two distinct procedures have been done. Why? Because two stents have been placed in two different duct. For that, you need to show, you need to append 15 modifier. Then again, if there is a separate placement of stent in both right and left. So, for example, a hepatic duct, there is right and left hepatic duct, right? So, in right hepatic duct, if they are placing a stent, and in the left hepatic duct, they are placing another stent, again, you have to code 43274, comma 43274 with 15 modifier. So, this is the second scenario. Then, third scenario, placement of two side by sides. For example, in the same duct. Okay, if it is, for example, in right hepatic duct itself, they are placing two stents side by side. In that case, also you have to code, you have to report for those two stents separately. So again, 43274 and 43274 with 15 modifier. So these are the three scenarios you need to append 15 modifier along with the CPT. Okay, so why? Because this is for each stent. So how many stents they have been placing in that common duct or hepatic duct, whatever the duct they are placing, you need to code for each stent separately, appending 59 modifier. So that is the guideline. If they are coming to remove the stent, okay, or remove the foreign bodies or whatever, you have to code 43275. Okay. But if they're coming for removal along with exchange, that is nothing but replacement. Okay. So if they will come to remove the old stent and replace it with a new stent, then you'll be coding 43276. Okay. Now if they are coming for a balloon dilation. Okay, so if they're coming for a balloon dilation of biliary or pancreatic duct, if there is any stricture, so there might be some strictures present in the ducts. Okay, whether it is biliary or pancreatic. In that case, you will be coding, and if they're doing balloon dilation, in that case, you'll be coding 43277. Okay, so this is for each duct. Okay, again, why? Because balloon dilation will be placed in one duct. If it is placed on another duct, then again, you'll be coding 43277 with 59 modifier. Okay, if they are destroying any tumors or polyps or lesions, okay, we call it as ablation. If you're doing it, then our CPT is 43278. So this is all about ERCP, guys. Okay, so mostly they will just ask you what is ERCP. Okay, and then they will ask you the guidelines which I just told you. Know, like for example, if there are two stents placed in one duct itself, then they will ask you how many like CPTs you will be coding. So you have to say that for each CPT, for each stent, we need to code it separately. So this is how you need to answer. Okay. So coming to colonoscopy, which is very important. So they will ask you a lot of questions in colonoscopy. I hope you guys can hear me. Yes, no.
Yes, yes.
It would be nice if you guys respond to me because I don't know if I've lost the connection or something. Okay, fine. Okay, so we also have a procedure called appendectomy. So what is appendix, guys? So what is appendectomy?
Removal of appendix.
Okay, so yeah, removal of appendix. So appendix nothing but a small, pouch which actually looks like a size of a small finger. Okay, so this is attached to a large intestine. Okay, from the cecum. Okay, so mostly it doesn't have much role. Okay, but sometimes it potentially stimulate some immune responses, or it can, store some undigested particles. So that is what mostly, um, you know, scientifically based, what to say, research about appendix is that it stores undigested particles. Okay, for example, stones, like, or for example, we can say hair, you know, or, some people, mostly who are nail biters or something, they undergo appendectomy. Why? Because most of the nails, they say it is like undigestible particles, so it gets sedimented in the appendix. Okay, so we believe that this is the role of appendix, but mostly it doesn't have an exact function in the humans. So that is why even if you remove it, it doesn't affect you, right? So yeah. So what are the common reasons for appendix inflammation, or we call it as appendicitis? Nothing but um, it's a kind of an infection caused by the if the appendix gets full, or it reaches beyond its storage capacity, it can get bulged, or it can get inflamed, or it can get infected. Okay, uh, and which requires a prompt treatment. Okay, if it is left untreated, it can burst and it can spill the materials into the peritoneum. Okay, so again, that becomes complicated. So before that itself, the provider or the surgeon will request or advise the patient to get operated. Okay, so as I told you, appendicitis is nothing but inflammation of appendix, okay, caused by blockage, or caused by some like mucus or whatever, right? Because of the blockage, it gets infected. Okay, so when appendicitis occurs, the patient will have a very severe pain in the lower abdomen, exactly in the right lower abdomen. Okay, so sometimes if it is so severe that the patient might get vomiting to nausea, vomiting, fever. Okay, so all these will come. So mostly these days appendicitis is treated with surgery. We call it appendectomy. Okay, that too using laparoscopic. So mostly these days they use laparoscopic, and previously they used to do open appendectomy. Okay, so now coming to the CPT. So we have appendectomy is for open 44950. Okay, and this is for like unruptured. If the appendix is not ruptured, then we have to CPT 44950. This is for open appendectomy. These three procedures means open these CPTs are for open. We have a separate CPT for laparoscopic. So now coming to the CPT 44950, this is for ruptured appendix. So as I told you, if it is ruptured, the materials inside the appendix can spill into the peritoneum, which can further cause complications such as infection or generalized peritonitis. So if that is the case, you'll be coding 44960 if it is again for open. Now, coming to the add-on CPT 44955. So this CPT is mainly used when the appendectomy is done along with a major procedure. Okay, so major procedure, like in a major procedure, the patient also might, the provider or the surgeon might also have found that, wait a second, guys. Yeah, so what happens is that, right. So what happens is that the patient might come in for a major surgery, okay, and along with that, the provider might have suggested or advised the patient, or had of like told the patient that he has appendicitis too, and it is in a chronic condition and it has to get removed. So in that way, what happens is that during the major operation, they will do appendectomy too. In that case, you'll be coding for major operation. Along with that, you have to add the add-on code. Okay, so that is the case. So might be it can be a very major operation. Along with that, you need to give this add-on code 44955. Okay. Yeah, so sorry guys. Yeah, so during major procedure, if they are, this CPT you can only give if they are indicating that, okay, that appendix has been, there is appendicitis and they are doing appendectomy. In that case, we'll be coding 44955 along with the major procedure. Okay. Now, if there is incidental appendectomy, for example, they might be doing a major procedure. In that scenario, what happens is that during operation, that is during the procedure, the surgeon might see that there is a very inflamed chronic condition of appendicitis. So at that moment itself they will do appendectomy. Okay, so this is without a warrant, right? So this is without a warrant. They are not giving a indication that he already has and he has come for this procedure. But here it is like during operation, they will find that the patient has appendicitis. So during that, they will take away that appendix. So in that case, we have to append 52 modifier. Okay, so this is a kind of an to report incidental appendectomy during an abdominal surgery. If it is necessary, if a client says, then you can append 52 modifier. Okay, so this is a guideline, guys. Mostly we don't use it. We haven't seen any scenarios using this. Again, some of the guidelines, some clients don't accept it, right? Because they need full, payment. So sometimes the client won't, or the uh, payers won't accept this. Okay. So these are the three scenarios we can, append the CPTs for appendectomy. So, and again, this is for open procedures, guys. Okay. But mostly we'll be seeing laparoscopy procedures. For laparoscopy, surgical, we have 44970. This is for unruptured, which is not ruptured. And this is for ruptured. Okay. So for example, they say that they have like ruptured appendicitis and they've come for appendectomy. Okay, in that case, you'll be coding 44979. Okay. Wait a second, guys. I'm trying to find some. Um, they have CPTs called cystectomy. Just trying to find where it is because it is mixed. I don't even know where it is. Okay, fine. I'll just tell you once I find it. Okay, coming to cholecystectomy. Sorry, colonoscopy. Okay, I couldn't find it here. Right? So we have CPTs for colonoscopy. We have like a very big guideline. Okay. So colonoscopy is examination of entire colon, guys. So entire column in the sense you can see it here. Yeah. So like if the scope is getting inserted through anus, through the rectum. Okay, this is the scope, okay, and it is going through the descending colon, then this splenic, it crosses splenic flexure, and it has, yeah, this is splenic flexure, this is the hepatic flexure over here. Why? Because here's the curve, here is your spleen situated, and here's your liver situated. Okay, so that is why it is called splenic flexure over here, and it is called hepatic flexure. Okay, so if the scope reaches till your cecum, then you will consider it as full colonoscopy done. Okay, so you can see the This is a colonoscopy decision tree. It is very important, guys. Okay. They will ask you in the interview. Tell me about the colonoscopy decision tree. When you'll be using 53 modifier. When you'll be using 52 modifier. Okay. Yeah. Sorry, guys. My laptop got turned off because of no charge. Okay. Am I audible, guys?
Yes.
Yes, sir.
Okay. So you can see the colonoscopy decision tree over here. Is my screen visible?
Yes.
Yes.
Okay. Okay. Right. Thank you. So, if a patient goes to undergo colonoscopy, so we have like two separate procedures. So one is diagnostic procedure. Diagnostic procedure, like when they come in for to check in if the patient has any any conditions, like for example some bleeding, or some lesions or some tumor, okay, that is bleeding through the rectum. So for all these cases, they will be undergoing diagnostic colonoscopy to check or to visualize the structure, the lumen, to check if there is any abnormality, right? So once they confirm with any abnormality, okay, and if they are doing a treatment for that, for example, if they are doing some cauterization, control of the bleeding, or if there is any tumor they have found, or if they're removing the tumor, if they're removing a polyp, okay, so in that case it will turn it as therapeutic. So diagnostic will convert into therapeutic, right? Because there is some treatment going on, so you'll be considering as coding under therapeutic procedure. But if it only stays for diagnostic, for example, patient comes in with some symptoms and he gets a diagnostic done, or sometimes they might do some biopsy also. So in that case, you can call it for biopsy. But if there is no biopsy, nothing, they are just coming and visualizing the like just only for colonoscopy visualization, then you'll be coding for diagnostic CPT. Okay. So as I told you, two procedures, diagnostic and therapeutic. So for diagnostic, if it does not reach the splenic flexure, for example, they might enter the scope. Okay, the scope might enter into the anus rectum, but it will only reach till the descending colon. It has not crossed the splenic flexure. In that case, we'll be considering it as flexible sigmoidoscopy. Okay. So that time we'll be considering it as a flexible sigmoidoscopy. You'll be coding 43330. 43330 for diagnostic flexible sigmoidoscopy. So that is what the CPT is for. Okay, why? Because I told you at the beginning itself, you can only, take it as colonoscopy, full colonoscopy, if the scope reaches till the cecal. If it gets stopped somewhere here or somewhere here, you need to code it accordingly. So if the scope reaches till the descending colon, but it has not crossed the splenic flexure, then you'll be coding it as flexible sigmoidoscopy. Okay. Why? Because your rectum is here, your sigmoid colon is here, your descending colon is here, right? Then you have, if um if the scope has crossed beyond the splenic flexure but not to the cecum. Okay, so it has crossed beyond the splenic flexure. Okay, but it has not reached the cecum. Then you can be coding it as colonoscopy, but with 53 modifier. So what is 53 modifier?
Discontinuous procedure.
Okay, and what is 52 modifier?
Reduced procedure.
Okay, correct. So, who is this?
Kiran.
Okay, thank you, Kiran. Okay, so modifier 53 is used for discontinued procedure. So I told you, right, when discontinued procedure is given, so it is like to indicate that the surgical or diagnostic procedure was started but discontinued due to some circumstances or condition that threaten the well-being of the patient. Okay, so one thing is that during colonoscopy, most of the time, during a procedure, they will, evacuate all the stool, everything. They will, prep the patient well, then only they will do colonoscopy. Otherwise, the scope won't go inside. Okay, because the large intestine, it stores the feces, right? So once the feces clears, then only we can pass the tube, right? Pass the scope. So if there is any stools or anything, stuck inside anywhere of the colon, and because of that, the scope cannot be pushed into. So in that case, what they'll do, they will take back the scope. So in that case, we'll be coding it as 53. And that is why it might not go beyond the spleen. I mean, might not touch, like, reach the cecum. Okay. But if it reaches a cecum, then we'll be considering it as full colonoscopy, and we have the CPT 45378 for diagnostic. So these I explained you is for diagnostic procedure. Okay. Now coming to therapeutic. So if likewise, if it doesn't reach a splenic flexure, we'll be coding it as flexible sigmoidoscopy. But they might have, taken some, polyp removed, or any lesion destroyed, a polyp removed, or any cauterization, anything, some kind of treatment they might have done in that area. Okay, till here they might have done. So for that, we'll be coding under flexible sigmoidoscopy. You need to select the CPT accordingly. Okay, for which therapeutic or which treatment they have done. For that, you need to, you know, um, take the CPT codes. Then, coming to beyond splenic flexure. So if the tube has crossed the beyond, it crossed beyond splenic flexure, but not reached cecum, then in that case, as I just explained you for diagnostic procedure, we can call it as colonoscopy. Again, we need to apply 52 modifier for reduced services. For therapeutic procedure, you'll be coding 52, and for diagnostic, you'll be coding 53 if it has not reached the cecum. Okay, so this is a guideline we need to follow. Okay, this is a common colonoscopy guidelines. You need to apply this in your coding. Okay, so in therapeutic cases, if it has not reached the cecum, but it crosses beyond the splenic flexure, okay, and if they have done any procedure, okay, it can be a biopsy, it can be a removal of lesion or polyp, it can be, uh, you know, some, what to say, to the patients here. Or it can be any injections, or, control of bleeding. Okay, so for all these, if they have done beyond the splenic flexure, we will be coding under the code set 45379 to 45398 with 52 modifier. 52 modifier is to state that it has not, procedure was not completed, but it was reduced, like, before the procedure was to be completed, it was reduced. Okay, so in that case, we'll be coding 52 modifier. Okay. Now come, if it reaches, if the scope reaches to cecum, if it reaches to the cecum, then you'll be coding as full colonoscopy. Again, you will be coding under these CPTs. Okay. So I'll just walk through the CPTs. It is very easy. like whatever we saw in the esophagoscopy or EGD, the same scenario over here, but this is doing in the like they are doing it in the colon. So that is why we call it as colonoscopy. Okay, but otherwise the procedures are all same. Okay, so 45378 is for diagnostic. So you can see here. Okay, if they are collecting any specimens by brushing or washing, okay, or if they're just coming to visualize the colon alone, in that case, you will be coding 45378. Okay, so here, if you need to code this set of CPTs, the tube should have reached beyond the splenic flexure. If it doesn't reach the spleen, if it doesn't cross the splenic flexure, then you have to code under sigmoidoscopy. Okay, so this is the one thing you need to keep in mind. Now coming to the removal of foreign bodies, if they are removing any foreign bodies or anything, we will be coding 45379. And if they're taking any biopsy, whether it is single or multiple, you have 45380. If they're doing some mucosal injection, like India ink or some kind of corticosteroids or some kind of botulinum toxin injection. So in that case, you'll be coding 45381. And if they're controlling any bleeding formed by the lesion or tumor or polyps in the colon, then your CPT is 45382. They are ablating any tumors or polyps and lesions, you have 45388. If they are removing, lesions or any polyps through hot biopsy forceps, you have 45384. And if they're using snare technique, you have 45385. So this is for balloon dilation. If they are, there's any stricture in the colon, and if they are, using a balloon dilation to remove the stricture, then your CPT is 45386. They're placing any stent, you have a CPT 45389. So these are the, yeah, you also have EMR. So mostly they will ask for colonoscopy EMR. Okay, that is colonoscopic endoscopic mucosal resection. So in that case, if they will ask you what are the three criteria, you can explain. The all criteria is the same. Whatever I told you is the same. The procedure is the same, but it varies for different type of scopies. Okay, like for colonoscopy, we have this set. We have this CPT. For endoscopic EGD, we have different CPT. For esophagoscopy, we have different CPT. Okay, they are doing now. They might have found some hemorrhoids during colon. You know what is hemorrhoids? What are hemorrhoids, guys? What are hemorrhoids or piles? So these are nothing but inflamed veins. Okay, so if there is any swollen or inflamed veins in the anus or in the rectum. Okay, so we call it as hemorrhoids. So we have like types internal hemorrhoid and external hemorrhoid. Okay, so sometimes these internal hemorrhoids can be prolapsing too. Like prolapsing sense, it will come like it will just protrude itself from its normal position. Okay, so people what they will experience a lot of symptoms like pain, discomfort, sometimes bleeding also. Okay. Uh, So if they have found during colonoscopy diagnosis that the patient has an internal hemorrhoids and now they are removing it. Okay, if they're removing it or if they're doing some band ligations through the colonoscopy process, then we have 45398. Okay. So these are the CPTs for colonoscopy, guys. Okay, so this is very important. Colonoscopy decision tree, they will ask you, I need to explain you, and you need to explain. Okay. Um, Coming to the hemorrhoidectomy. So hemorrhoidectomy is nothing but removal of the hemorrhoids. Okay. So we have different code set over here. Starts from 46221. So the 46221 is for hemorrhoidectomy internal by rubber band ligation. So here the patient provider what he'll do is that he will ligate or tie off. So ligate is nothing but they will use a band, okay, terming it as a rubber band. They'll be using that and they will just tie the base of the hemorrhoid. Okay, so that what happens after some time or after some days, the hemorrhoids will dry. Okay, it will become dry because of the ligation. the hemorrhoids won't have the blood supply. The blood supply will be cut off, and due to the lack of blood supply, the hemorrhoids will become dead. It will turn dead and it will shed itself over time. So this is one method they'll be doing it. So 46221 is for internal hemorrhoids by rubber band ligation. Okay, so 46945 is for hemorrhoidectomy internal. This is also for internal hemorrhoids, but not ligation. Okay, so other than rubber ligation, it can be destruction. Okay, like they can do procedures, uh, such as suturing. Like they might suture they'll just cut off. Okay, they'll just take away, excise the hemorrhoids, and they can also do some suturing. Okay, so they might also do sclerotherapy. So sclerotherapy is nothing but they will inject a medicine so that it shrinks. Okay, and after that they will use some coagulation or something, coagulator, and they will use a infrared light. Okay, and or sometimes they might use some heat, intense heat. Okay, so that this hemorrhoids gets coagulated, and they will excise down that hemorrhoids. In this CPT in 46945, this CPT is for any type of method other than ligation. Okay, so in that case, we'll be coding 46945, and this CPT is for without imaging. Sometimes they might use imaging guidance, but if it is without imaging guidance, you'll be coding 46945, and this is for single column or single group of hemorrhoids. Okay, only single hemorrhoid will be there in that area or column. Okay. Now coming to 46946. So this is for hemorrhoidectomy, internal hemorrhoids by ligation other than rubber band. So if they're doing ligation other than rubber band, okay. Again, if this is for two or more hemorrhoid columns, so there might be two or three hemorrhoids present in that a particular area, and if they are doing the procedure without imaging guidance, it will be coding 46946. Okay. Now this is for 4694. This is for internal hemorrhoids. Okay. Transanal hemorrhoidal dearterization. So here, what they will do is that using ultrasound guidance, they will um, plicate it. Okay. So this is a procedure, a special kind of procedure. They will use a probe, Doppler probe. Okay, and they will use this and through the anus. Okay, wherever they find the hemorrhoids, they will use it. They will turn on the Doppler and they will slowly rotate the probe. They will identify the hemorrhoidal arteries. So that is what we call as dearterization. So hemorrhoidal arteries, what they will do, they will once they identify the artery, okay, then they will turn off the Doppler and they will tie the artery using suture. Okay, tie in the sense they'll suture it. So it means it will become tied, right? So they will use suture it using absorbable suture. Okay, so they perform this procedure on two or more hemorrhoidal columns. Okay, so we call it as hemorrhoidal dearterization. Dearterization is nothing but they'll just find the hemorrhoidal artery which supplies blood to the hemorrhoids, and they will just ligate it using some sutures. Okay, so this is what they do. So 46220. This is for excision of single papilla tag. So if there are a lot of tags, anal tag, skin tags over the anal region, over the anus, and if they are just excising it, and if it is for just single papilla or single tag, we have 46220. And if it is of multiple tags, multiple skin tags, and they are excising it, we have 46230. Okay. Now coming to the external hemorrhoids. So excision of thrombosed. So what is thrombosed hemorrhoids, guys? What do you mean by thrombosed?
Blood sibling,
Bleeding, sorry.
blood clot.
Blood clot, exactly, blood clot. So if there is any blood clot which forms inside a hemorrhoid, so it can cause pain, swelling, and sometimes bluish discoloration also. Okay, so mostly in the external hemorrhoid, this kind of thrombosed hemorrhoid can occur. So if they are excising a thrombosed hemorrhoid, external thrombosed hemorrhoid, we have CPT 46320. Okay. But now if they're removing the whole hemorrhoid, like, if they perform hemorrhoidectomy, okay, external two or more columns, we have CPT 46250. Okay, so this is how a prolapsed hemorrhoids it can protrude out of the anus. Okay, so through the naked eyes, the surgeon or the doctor can see the hemorrhoids. Okay, and if they are doing hemorrhoidectomy, this is a combo course. So mostly people might have internal as well as external hemorrhoids. So if they are doing a hemorrhoidectomy for single column, internal and external, we have 46255. Okay, and if they are doing two or more columns or groups, we have 46260. Okay, so mostly you can see these kind of scenarios. And this is yeah, coming to the cholecystectomy. What is cholecystectomy, guys?
Removal of gallbladder.
Yeah, removal of gallbladder. So again, you will see a lot of scenarios, 90% scenarios in cholecystectomy, appendectomy, colonoscopy, EGD. So these are the random, scenarios you'll be seeing for in the 4000 series. So in cholecystectomy, they will be removing the gallbladder. Okay. So here they will be removing the gallbladder stones as well as the gallbladder, and this is for laparoscopic approach. So mostly you'll be seeing laparoscopic approach only. So we have 47562 for that. Then we have 47563. So 47563 is mostly used in scenarios where they do cholangiography, we can say. So here, the provider will remove the gallbladder, okay, using a laparoscope. Okay, so before that he might perform a cholangiography. So cholangiography is nothing but they will inject dye to visualize the biliary ducts. Okay, so if they are like, you need to read the report on line by line, and you need to see if they are using any if they are performing any cholangiography by injecting contrast dye into the gallbladder. And if they are interpreting the report stating that bile ducts, like they will interpret like bile ducts visualized patent or abnormal or cystic duct, they will also um, what to say, check on that too. Okay, if they clip the cystic artery and duct and then they perform the cholangiography by injecting contrast dye, then definitely you won't be coding 47562. You will be coding 4747563. Okay, so you need to check if they are performing cholangiography or not. Okay, mostly people will do blunder mistake in that. Inside they might have used some injecting, they might have injected contrast dye, and they might have viewed the cystic ducts and for abnormalities, or and then what they'll do, the coder will code it as 456, 47562. But no, their CPT should be 47563. Why? Because they have done cholangiography. Okay. If they are doing cholecystectomy with the exploration of common duct, if they are exploring common duct, and if they are performing the gallbladder removal, then your CPT is 47564. Okay. So these three scenarios you can see. This is for open type, guys. Open cholecystectomy, you have 47600. And if they're performing cholangiography, then you have 47605. Okay, you also have cholecystectomy with exploration of common duct, you have 47610. These are for open approach. Okay. Come to the hernia repair. Again, frequently seen cases: hernioplasty, herniorrhaphy, or herniotome. So what is hernia, guys?
Protrusion of the colon.
Colon, huh? Okay.
Yes.
What else? So hernia uh, occurs when in any organ. It is not that colon. It can be stomach. It can be small intestine. It can be any organ. Okay, any organ or any tissue which protrudes through a weak spot. Okay, so there might be a weak spot in your abdominal region. Okay, the muscle, the surrounding muscle, the connective tissue, everything will be weak. Through that weak spot, the organ or tissue can protrude. Okay, so mostly this happens in the abdominal wall. So it is a kind of a bulge which can be seen. It can be, it is visible to a naked eyes, especially when someone strains, like for example, coughing or weightlifting or walking or running, right? So at that time, this becomes more visible. This comes out, this bulges out. Okay. Sometimes hernias are harmless. Sometimes hernia needs attention, surgery. Okay. So we have types of hernias. We have inguinal, we have femoral, incisional, umbilical, we have hiatal, we have epigastric, we have spigelian. So all these are type of hernia. So what is inguinal? Inguinal hernia, it's most common type, and you can find this in the groin region. So mostly men can have inguinal hernia. Femoral hernia occurs in the upper thigh, like okay, below the groin region, in the upper thigh, mostly common in the women. Okay. Then the incisional hernia. So this incisional hernia develops in the site of a surgical incision, previous surgical incision. It can develop. Okay. Then we have umbilical. Again, it is very frequently seen, mostly in the children, right, or in the obese patients. Okay, why? Because this occurs around the belly button in the umbilical region. Okay. Then we have the hiatal hernia. So hiatal hernia occurs, in the upper gastric region, mostly when a part of stomach pushes through the diaphragm into the chest. Okay. So in that case, we call it as hiatal hernia. Then we have epigastric. So epigastric occurs in the again in the upper epigastric region of the stomach. Okay. Um, so it is between your diaphragm, your upper, your sternum, the end part of the sternum to your belly button. It occurs between. So that is what we call it as epigastric region of the stomach. So in that area, if there is any hernia or any bulge, we call it as epigastric hernia. Then we have this spigelian hernia. So spigelian hernia, it occurs on the side of the top, okay, below the navel. Okay. Sometimes the hernias are congenital, like, it can be caused by a weakness in the abdominal wall from the birth itself. And sometimes hernias can also develop over time. We call it as acquired hernia. Okay. So, what are symptoms of hernia? We can see visible bulge, okay, especially when standing or, bending or straining. And sometimes patient might have pain and discomfort, or they might not. Okay, sometimes it can be painless, or sometimes it can be painful also. Okay, and so these are the symptoms of hernias. Hmm. So whenever you're coding for hernias, you need to check for the age. Okay, and you need to check whether the patient has the hernia for the first time, that is initial or recurrent. You also need to check if it is reducible or irreducible. That is one thing. We also need to check if the hernia is a normal one, okay, a harmless one, or if it is incarcerated or strangulated. Okay, so here you will get a question like what is incarcerated hernia and what is strangulated hernia? Okay. Hmm. So, incarcerated, I'll tell you what is incarcerated. So, incarcerated hernia occurs when a portion of organ or tissue gets trapped in the hernia sac. Okay. So, like for example, there might be an, bulging in over to the mid abdomen region. Okay, and what happens? Sometimes small intestines gets twisted, and it gets trapped in this hernia sac. So this cannot be pushed back into the abdominal cavity. So we call it as incarcerated hernia. Okay. But here the blood supply to the trapped tissue is intact, like the blood supply is proper, it is going. So there is no strangulation, but it is incarcerated, like it is trapped, right? What is strangulate? So in strangulate hernia, so if it becomes complicated, if this incarcerated is trapped in small intestine is not, addressed, okay, it is left untreated. So time pass on, it becomes a serious condition. What happens? The trapped tissue's blood supply will cut off. Okay, and this potentially will lead to ischemia. We call it as ischemia. That is nothing but tissue death. Okay, so this is what we call as strangulation. So whenever you're getting a hernia chart, first check what kind of hernia it is, whether it is inguinal or what is the type of hernia? Check inguinal or umbilical or hiatal, whatever it is, because according to the types of hernia, you have different CPTs, right? Then you need to check for the age. So we have certain age criteria in order to select for the CPTs, right? Then you need to check for the whether it is reducible or non-reducible, or whether it is incarcerate or strangulate. So that is one thing. And again, you need to check whether it is initial or recurrent hernia. Okay. So you have CPTs from here. So we have 49491. This is for repair of initial inguinal hernia for infant. Okay, less than 37 weeks. So these CPTs are mostly used for the infant. Okay, so you need to check for the age or weeks of gestation. Okay. So this also includes hydrolectomy. Okay, if the baby has a hydrocele and we are removing that too, then it is included in the CPT. This is for reducible hernia. Okay, and if it is strangulated or incarcerated, you have 49492. Right. Then if it is a full-term infant, okay, younger than 6 months, okay, so you have 49495. This is for inguinal hernia. Okay, so we're seeing for inguinal hernia only. Incarcerated or strangulated, we have 49496. Now comes to adult. Okay, so this is not for adult. I think this is for age 6 months to younger. Yeah. So if the baby is above 6 months but below 5 years, then your CPT for inguinal hernia initial is 49500 and 49501. So this is for reducible, that is normal kind of hernia. But if it is incarcerated or strangulated, you'll be coding 49501. Okay, so these are for adults from here. Reducible, repair of initial inguinal hernia, age 5 or older, and 49507 is for incarcerated or strangulate. So these two is for initial inguinal hernia, and this is for recurrent inguinal hernia. I told you, right? You need to check for initial or recurrent. You need to check for normal inguinal hernia or incarcerated or strangulate hernias. Okay, you need to check for age. So these criteria. Check if the patient hernia is a normal hernia or if it is incarcerated or a strangulated hernia, because we have different code set for that, right? Okay. So you have recurring inguinal hernia over here, you have strangulated CPT for here. And if the patient has initial humeral hernia, any age reducible, then you have 49550. If it is strangulated or incarcerated, you have 49553. If it is a recurrent femoral hernia, you have 49555 and 49557 for incarcerated or strangulated femoral hernia. So likewise, you have CPTs for all the hernias. So this is for repair of anterior abdominal hernias. So here epigastric, incisional, ventral, umbilical, spigal. So all these are included in this CPT 49591. But here you need to check for whether it is initial or recurrent. and the size of the defect, less than 3 centimeter or more than 3 centimeter. So that is one thing you need to check for. And this CBT is for any approach, guys, whether it is open, laparoscopy, or robotic. You will be coding 49591 if it is done for epigastric or umbilical or incisional hernias. Okay, so you can read the whole description over here and you can understand. So if it is less than 3 centimeter and if it is incastrated or strangulated, you have 49592. So again, this varies for the defect size. Okay, so you need to check for the defect size also. And if the defect site is not mentioned, you can query the provider. Okay. So we saw this for initial, right? Now we have for recurrent. So repair of anterior abdominal hernias, recurrent, okay, including mesh. If they are, placing any mesh or anything, that is also included in the CPD. You don't have to code it separately. Okay. Again, this also is based upon the size. If it is less than 3 centimeter, we have 49613. If it is incastrated or strangulated, we have 49614 for less than 3 centimeter. If it is 3 to 10, we have 49615. Okay, and for incastrated or strangulated for 3 to 10 centimeter, we have 49616. If it is greater than 10 centimeter, we have 496769617 and 49618. Okay. So these are the hernia repair CPTs, okay? That is one thing. So tomorrow I'll discuss some of the charts in 4 series, okay? And tomorrow we'll also start the 5 series. So 5 series will be having, like, it's very short again. We don't have much topics. We only have some reproductive topics, and as well as the delivery. We also have some topics on urinary bladder system. Okay, we'll check that too. Right. So tomorrow I will connect by 8, guys. Thank you.
Yes, sir.
Thank you, Sonia. Thank you.